Hi, good morning, good afternoon, wherever you are. My name is Manny Vega. I'm on the marketing team here at Truven, and I'm very excited to open up today's webinar. This is Healthcare Affordability and Beyond, Navigating Cost Trends in 2025. So this is one of the inaugural or annual events that we do here at Truven, putting on a trends webinar at the start of the year. And we really appreciate everyone for making the time to join us here today. Just a bit of housekeeping before we start. Our session is being recorded, and a replay will be available after the webinar, along with the presentation slides. So we'll make sure to get that out to everyone after the webinar is complete. If you take a look at the panel on the right side of your screen, you'll see a few different icons. In particular, I wanted to bring your attention to the icons, the poll question icon. So we'll actually be bringing up a few poll questions at the start of each section. You'll see them pop up briefly on the screen, and we'll leave them up there for about a minute, but they'll continue to be accessible after we pull them off the screen. So all you've got to do if you want to answer a question is click the poll button on the right side of your screen. You can leave your answers. You'll be able to see results using that panel as well. And we'll also be sure to share results after the event is complete. So we do encourage you to participate and share your perspectives as we prompt them. So a bit about us, Truven, for those who aren't already aware, I know we have some folks in the audience who may not already be aware of Truven. We are a part of Merative. That's a healthcare technology company. Truven has a 40-year track record of introducing innovative market-leading solutions in the area of healthcare data and analytics. You can see a few of these solutions at the top of the screen here. But in particular, I'm going to call out Health Insights, which is really for the benefits leaders and the healthcare analysts in the room here today. That's really where we're going to focus a lot of our attention. With Health Insights, we help organizations understand, enhance, and maximize healthcare data to drive better health and financial outcomes. And we do that by providing best-in-class data quality, actionable insights, and trusted healthcare consultancy. So you can see on the right-hand side here, we have a tremendous group of clients, really some of the leaders in their respective industries. And we've used Health Insights to help them identify areas of opportunity where they can improve healthcare quality or uncover millions in program savings. Many of the trends and the data that we're going to share in today's webinar come from MarketScan, which is another Truven solution. We're the only healthcare analytics vendor in the space with complete access to MarketScan, which is a de-identified closed claims data set. It represents over 293 million covered lives, sourced from a diverse pool of payers and employers. So we make some of those MarketScan data sets available to our customers in a few different ways. Some clients choose to license methodologies and MarketScan data sort of on its own. Others, again, use Health Insights as their healthcare analytics platform and end-to-end solution, which allows you to benchmark population data against MarketScan at various levels from national, state, local, and industry levels as well. So really just try to stay flexible to meet clients where they are and help them get the most value of that data set. And I share that to say that, again, a lot of the trends that we're going to be sharing today come from this MarketScan data set. Our presenters today are part of the Truven Applied Analytics and Consulting Services team. They work with our clients to be proactive around providing advisory services to evaluate their population health trends, really help clients dig into their data, understand and identify ways to improve benefits programs or healthcare programs. So today's webinar really draws on their collective expertise from that work. And you can see here the topics that we're going to cover. We'll have a regulatory update. We'll talk about GLP-1 drug trends, mental health and well-being, and we'll talk a little bit about pricing strategies as well with our various SMEs here ready to cover those topics. And so with that, I'm going to turn it over first to Brian Briegel, who is our regulatory expert, who's going to provide a compliance update. So Brian, over to you.
Very good. Thank you, Manny. Appreciate that. So thank you, everyone. As Manny said, I'm Brian Briegel. I do focus on regulatory and compliance. Happy to be here. Been with the company for 20-some years now, and for the past 17 of that, focusing really on regulatory and compliance activities that impact health insurance issuers and employer group health plans. So as we look forward to 2025 and beyond, and regulatory and compliance focuses, we wanted to go ahead and bring up a poll to ask you what your priorities are, or your organization priorities for compliance activities in 2025 and beyond that might be top of mind. So if you take a minute, please, to go ahead and weigh in on what your priorities are. We'll go ahead and keep moving through the slide presentation. So first off, let's look forward, look back in order to look forward on the idea or the concept of past performance is a good predictor of future behavior. And we recall back to the first Trump administration, the very first executive order, in fact, signed on Inauguration Day, was to repeal the Affordable Care Act. And we know that we didn't see a repeal of the act, but we did see actions taken to somewhat diminish the act itself without a full repeal. For example, there was the repealing of the individual mandate by setting the penalty to zero for not having insurance coverage, elimination of taxes such as the Cadillac plan tax, and reduced funding for outreach and education, and shortening of the enrollment window for those wishing to enroll in exchange plans. On the affordability front, there was action taken on a vehicle by way of the executive order called the short-term limited duration plans that many of you may be familiar with. These are short-term up to 3-month plans intended to bridge across gaps in a full medical coverage, perhaps between employment, having employment gaps to fill. And the executive order in the first administration moved these short-term limited duration plans. They're non-ACA compliant. They tend to have limited benefits. They don't have ACA protections. They can charge more, for example, for pre-existing conditions that might not have any out-of-pocket maximums, which can then be offered these products at a lower cost. They can be very attractive to a consumer. The executive order under Trump's first administration moved these to up to 12 months and up to 36 months or 3 years, right, with extensions and renewals. And there's some concern there, and there's differences across the aisle. So President Biden administration recently rolled these short-term limited duration plans back to the 3-month intended purpose of these plans. And we do think we might see a bit of whiplash here, and we anticipate that we will see the Trump administration once again revert these back to up to 3 years of enrollment. So to a consumer who might not know any better, they're going to potentially see what looks like a low-cost plan, but corresponding limited benefits and not having financial protections of an ACA plan. Looking back, we saw important action taken in the first administration around transparency, significant action on consumer protections against surprise billing. Again, all these initially triggered by way of executive orders requiring hospital price transparency and transparency and coverage regulation that required the public exposure and availability of machine-readable files across the provider, hospital side, as well as the payer side, and exposing those negotiated rates between payers and providers. There is some unfinished business in the payer space on the prescription drug machine-readable files. There was enforcement discretion for a while. Last September, the enforcement discretion was lifted, actually longer ago than that. So they are now being enforced. We have yet to see the prescription drug schemas. And of course, you need schemas to create the files. There's unfinished business on the transparency front. Executive orders also require the departments to work with Congress to legislate solutions around consumer protections and around surprise billing. And that came by way, again, of the Consolidated Appropriations Act of 2021. There are important transparency provisions, but the consumer protections came by way of Title I, No Surprises Act, which included the requirement of advanced explanation of benefits. These were to be in effect in January of 2021, in fact. But there is significant concern across the industry on how the standards for data transmission across providers, convening providers, co-providers, moving that data back to the payer so that a member can take what you get today by way of explanation of benefits post-service and move that all up front so that when a member who's covered under a plan and wants to use their coverage, they'll be given the provider's services intended to be rendered. They'll be given the charges expected to be rendered or submitted from the provider into the payer. And they'll return back on that advanced upfront pre-service estimate what the plan is going to cover and what the member out of pocket will be for that plan encounter. And again, this is important to have up front for consumers to understand what they're going to be in for if they choose to move forward with treatment. So this has been tabled. We've seen this move down the regulatory agenda. Very recently, in fact, moved from March of this year, a proposed rule. We expected March. That has now been slid down to the July time period. And I think there's some question, will we in fact see a proposed rule in July, or might this go back to Congress to reassess the requirements and how the sector might not be ready to implement the advanced explanation of benefits at this time. So for 2025 and beyond, we'll take a look at will there be similar activity to weaken the ACA? What about vaccines and vaccinations? And how about the fiduciary landscape? So first, the Affordable Care Act. Will we see actions to erode or further advance, and what might impact on costs be in the healthcare sector? There's question out there that will the new administration allow the enhanced premium subsidies to expire? They're set to expire. They were extended through the IRA. They're set to expire at the end of 2025. If they are allowed to expire, that could lead to up to 7 million to become uninsured in those plans. Some may be able to gain coverage through employer-sponsored plans or by other mechanisms, but the bulk of those may in fact remain uninsured. Will there be, again, rollback, as we saw in the first term, on that Affordable Care Act enrollment funding, outreach, education, advertising, and again, will they truncate the enrollment window? These are actions that won't repeal, but make it more difficult for members to understand their options for exchange coverage and a limited time window. So again, these things could diminish enrollments in insurance products. So when we think about, mentioned before, the short-term limited duration plans, we do expect the administration to roll those back forward again and allow enrollment up to 3 years, again, removing a number of people who have full coverage, if you will, under traditional medical plans, and certainly those that in the short-term limited duration plans do not have that ACA protection available to them. We think about cost impact, why we care about all this. Well, there can be potential revenue loss, right? If you have a lower number of enrollment in insured plans, payers will face a revenue loss, providers will have less patients to treat, and you're going to have people out there who don't have insurance and will have unmet treatment needs that could push costs further down the road. So we think about the revenue losses that this could drive, and you think about the recent reduction in payments on Medicare side from CMS, the 2.8% reduction on physician reimbursements. That again could drive pressures to make up those reduced payments over to the commercial payer side. Additionally, another part of the Inflation Reduction Act allowed CMS to negotiate lower prices for certain high-cost single-source drugs. And certainly the pharmaceutical manufacturers do not have to honor those reduced prices over to commercial payers. So we think all these things kind of bring it together and can put pressure on the theme of driving costs over to commercial plans and payers. There were some things also done to advance the Affordable Care Act requirements. So it's a little bit of a paradox. One way to erode it, and also some methods to, in fact, advance Affordable Care Act requirements, again, on the transparency side, both provider and payer. And we do think that these cost trends really heighten the value of the use of the machine-readable files. We know that the negotiator rates, the allowed amount files are out there, the hospital files are out there and available. But again, we'll go back to the prescription drug machine-readable files. We anticipate seeing a schema sometime this year. It is certainly delayed. And there's a rich volume of data in those files, including the negotiated rates for those prescription drugs, as well as the historical net price, that is net of rebates and price concessions. It's a look back of 180 days. It's the front 90 days of that 180 look back. But again, imagine having the negotiated rates for those drugs, as well as a historical net price, net of rebates and concessions. I think it's important data to be available to the public to understand the pricing in your pharmacy benefits. A bit about vaccines. There's been a lot of concern. Will the administration, a lot of noise, if you will, out there online in the news. What's the administration's posture going to be on vaccines, and what might impacts be around this? Again, we'll look back and say, vaccines have been a critical component of ensuring population health, bringing things back into perspective. Again, under the first administration, on a look back, the Trump administration developed the COVID vaccine under Operation Warp Speed, seen as a great success. There's a vignette of a quote here of Trump addressing the audience and the group that helped develop the vaccine, indicating that it was a great national achievement, racing quickly to develop a safe and effective vaccine at breakneck speed. So there is thought that the administration, when you think about their prior posture towards vaccine and vaccinations, as well as the administration's concern, and most administrations concerned about national security and economic security, and certainly and arguably vaccines have played an important role in this historically in both of these initiatives. So all this notwithstanding, we do know that if there's any potential if the administration or presidential attitude towards vaccine is positive and encourages that alone can increase uptake in vaccination rates, as well. And conversely to this, there's skepticism by way of just posture, let alone policy. It can have a dampening effect on vaccine uptake and drive down those rates. Moving down to potential impact and why we care. The CDC has demonstrated and provides statistics indicating that, hey, vaccines are already on the downward trend. And I pulled an example here of the child flu vaccination rate is down 3% year over year, 24 over 2023. And again, why do we care about this, right? The drop in vaccination rates can lead to a corresponding decline in population health, an increase in chronic illness and conditions that these vaccines were, in fact, developed to treat. So you could have a result of, some unhealthier population, not getting vaccines, and lead to downstream increased medical costs to treat those conditions and illnesses. We do think, however, there's not too much risk of any wholesale change in vaccine policy, notwithstanding any significant new scientific evidence that would suggest that vaccines are not safe or effective. However, there is concern, right, that if there is policy here, could it shift vaccines out of a preventative service category? And if that's the case, might it then move those costs and shift them over to the consumer, having them not be covered pre-deductible? And just 1 minute here on fiduciary responsibilities. Many of you may be paying keen focus to this. We do think in 2025 we'll continue to have employers considering what have they done, again, that look back to look forward. What have they done historically as a fiduciary of the plan? How might they be changing by way of reflecting on requirements of the Consolidated Appropriations Act, looking at litigation that we've seen in 2024, where we've seen members of the plan bring litigation suggesting the employer was not being a good fiduciary of those plan funds. So we think employers will continue to take a look at what are they doing to ensure their fiduciary responsibilities are being executed in good faith. Do they have compliance plans to ensure oversight of cost and quality for their vendors that are rendering services to members of the plan? And are they acting, again, in the sole best interest of their plan members? And then to the extent that the employer, as an employer, may have delegated those responsibilities or some fiduciary responsibilities off to a TPA, what are we doing to monitor those to ensure that it's not just written to a contract, but it's actually happening? How you have methods and control plans in place to review and ensure oversight and evaluation, once again, to ensure that we're being good stewards of the employer group plans funds. So thank you. And with that, I'll turn you over to Catherine.
Awesome. Thanks, Brian. That was really interesting. Some of the regulations that we're seeing coming down the pipeline. Hi, all. My name is Catherine Shanahan. I'm our Senior Pharmacy and Analytic Advisor here at Merative. My background's in pharmacology, toxicology, but I've spent the last 12 years working and managing with payers on healthcare and reducing drug costs. Looking ahead into 2025, we're expecting GLP-1s to continue to drive prescription drug trends. So I want to talk with you all today about that. We're expecting it might rise above $350 PMPY next year. One of the primary drivers behind this expansion is this expansion into obesity weight management GLP-1s. And so to kick us off, I'd like to poll you all on whether or not you plan to cover weight management GLP-1s in 2025. So these products include Saxenda, Wegovy, Zepbound. Are you planning to cover these medications into 2025 or beyond? And so we'll leave this poll open as I kind of continue through slides, and we kind of look at some of the data that we have in terms of market scan trends and some of the surveys that we've done. Next slide. So I know everyone on the phone is at least somewhat familiar with GLP-1 medications, so I'm going to keep my background really brief here. But essentially, this class of medications has been available on the market for nearly 20 years for the treatment of diabetes. But in recent years, it's expanded into including obesity and obesity-related conditions. On the left here are product designations, clinical outcome goals, and payment management strategies that are listed across two cohorts of GLP-1s. Those GLP-1 products that are used exclusively for diabetes, so this is like your Ozempic, your Mounjaro, your Trulicity, and then on the right side of that graph, those that are used for like expanded obesity management. So that's, your Zepbound, your Wegovy, Saxenda. On the right-hand side of the slide are a number of thought leadership articles and references from Merative around GLP-1s. So from benchmarks to trends to strategy recommendations, I highly recommend you bookmark these for after the call today. Next slide. So as I previously mentioned, GLP-1s have been in the market for nearly 20 years now, but it's only been in the past 5 or so years that we've seen this kind of exponential growth in utilization and spend. The graph here is market scan trends for patients per 1,000 and allowed amount PMPY for GLP-1s from 2013 to 2024. And then along the x-axis at the bottom is a timeline of FDA approvals. So we see utilization has skyrocketed from 4.8 patients per 1,000 in 2013 to 54.6 per 1,000 in 2024. Likewise, allowed amount PMPY has also followed suit. So from $13 PMPY in 2013 to $342 PMPY in 2024. So this is both due to GLP-1s becoming a standard of treatment for diabetes. It's only behind metformin in terms of utilization rates. And then also, like I said, expanding into obesity and broader weight management treatment. But we see in 2024 a slight plateau compared to 2023. By no means are we saying that GLP-1s are diminishing in their impact, but as payers are adding new utilization management criteria and enhancing benefit strategies, we're seeing kind of a tightening of this exponential growth. Likewise, in 2024, we didn't see any new branded drug approvals, only the entrance of a generic option for Victoza. But you'll notice that I mentioned it's a plateau for now. So let's talk about next what's coming down the drug pipeline. So this is another graph that many of you are familiar with. This is the GLP-1 drug pipeline that we've been monitoring here at Merative. Starting off on the far right are medications that are currently available on the market. Then as you move to the left, that's where we start stepping into the drug pipeline. First with medications that are in phase 3 clinical trials and nearing FDA approval. Depending on the study outcomes and the strategic direction of these pharmaceutical manufacturers, these medications will likely come out in the next couple of years. You'll notice that there's not only some new combination drugs like Retroride, which is a triple agonist, which is different than many of the products on market right now are single agonist GLP-1s. But there's also an kind of expansion of current products on the market. So there's an oral option for Wegovy. There's an expansion of Zepbound into heart failure, cardiovascular, chronic kidney disease. And then as you continue to move left into the pipeline, these are drugs kind of further back in clinical testing. So these medications on the left side will probably take a bit longer to come to market, but easily can be fast-tracked based on study outcomes. So considering how many medications are currently in the pipeline, and honestly, some of the expansiveness of them, again, from single agonist to triple agonist, from expanding from injectables to oral medication, we know that this space is going to continue to be important to you all. And so we wanted to survey how you all are going to manage benefits going forward. Next slide. So in the second half of 2024, we sent out a survey to better understand how you all are covering GLP-1s and what strategies you're deploying to manage patients taking these medications. The results for this were fantastic. The plans that responded, we are representing about 4 million lives, ranging from 5,000 enrollees to 500,000 enrollees, and spanning a number of different industries. Collectively, these payers spent $1.5 billion on GLP-1s last year. But before I move into the results, I wanted to take a really quick moment and thank all the payers that contributed to the survey. Your participation allows us to create these kinds of dynamic benchmarks like this that we know will aid in benefit decisions in the coming years. Jump to the next slide. So here's the results. Starting off with coverage tier. So we split into, on the left, we have our diabetes-specific GLP-1s, and on the right is our obesity-specific GLP-1s. Not surprisingly, all of our survey respondents are covering diabetes-specific products, with a whopping 62% covering these medications as preferred, and that's in blue. Unlike obesity products, which we'll get into next, it didn't appear that coverage tier impacted utilization as much with the diabetes-specific products. So we saw non-preferred, that's in purple, which is typically associated with like a higher out-of-pocket for members, actually had a higher utilization than payers who cover these medications as preventive or preferred. And this is likely driven by these patients are diabetic patients that are really engaged with their specialist or with their provider, and so are taking these medications regardless of where they end up on a coverage tier. A little bit different for obesity medications. So for obesity medications, 35% of survey respondents do not cover these medications, meaning flip side 65% too. This is slightly higher than the industry rate of 60%. And again, that's most are covering them on that preferred tier in blue. Coverage tier did appear to influence utilization rates for obesity-specific GLP-1s. So we saw preventive in that green line having a 7 patients per 1,000 higher rate than those covering these medications as not preferred in purple. So our study indicated that for every 1 point reduction in utilization rate, it leads to about a $6 to $7 reduction in annual PMPY spend. This means payers who cover obesity-specific GLP-1s as preventive are spending about $40 to $50 more PMPY than payers who cover these obesity products as not preferred. Next slide. So next, we'll look at how utilization management criteria can not only impact utilization itself, but also drug adherence. So this slide is completely focused on diabetes-specific GLP-1s. First on the left, how respondents are deploying utilization management. Keep in mind that payers can have multiple types, right? You can have both prior authorization and step therapy as some of your utilization management criteria. And we saw 94% of respondents have some sort of utilization management criteria for diabetes medications. Most are using prior authorization criteria, which was expected. We've worked with many of you payers over the past years to build or strengthen these prior auths, really limiting into people who actually have diabetes who are engaged with various programs or various steps. And so we've worked with you all on those types, so it wasn't surprising to see that was really common. Also, unsurprisingly, we saw utilization management criteria influenced utilization rates. Payers who do not have utilization management saw utilization rates about 6 patients per 1,000 higher than those that do. So that's comparing that 42.6 in red to the 36.2 in green, and that's that top right graph. What did surprise us, though, was the residual impact on medication adherence. So payers that do not have utilization management criteria actually saw slightly higher adherence than payers that do. So that's comparing that average 251-day supply per patient in red in the bottom right graph to 233 in green. This may be related to quantity limits. It could be results of prior authorization renewals creating a barrier for patients. But I'd encourage you all to kind of track patients throughout their journey with GLP-1s. Why are they discontinuing treatment? Is it because of something, maybe the patient's experiencing, or is it potentially because of different benefits that we've deployed? Next slide. So then we looked at the same types of analysis for obesity-specific medications. Again, the graph on the left, we see all of our respondents who cover weight management medications have some sort of utilization management. Similar to diabetes products, prior authorization and quantity limits were the most common criteria, but we saw program participation actually bubble up here. 23% of payers are including this criteria for access to obesity-specific GLP-1s. Again, the top right graph, quantity limits appears to significantly impact utilization rates. But what was interesting when we look at the bottom right graph, adherence was fairly similar across all the criteria. What was interesting, though, is for obesity management medications, you see that the utilization rate, that adherence rate was actually quite a bit lower than what we had seen previously for the diabetes specific. So 175 average day supply compared to what we saw on the last slide, which was 233. So this could be patients not being prepared for side effects, not being comfortable with injectables, having difficulty maintaining focus, or even affording medications. So similar to diabetes patients, we'll want to track these patients at their journey through weight management products, identifying gaps or reasons for discontinuation of treatment. However, we know that diabetes and obesity patients will have different inflection points. So for example, using injectables is fairly common for a diabetes patient, but might be completely new to somebody who historically has hypertension or dyslipidemia, and so they've primarily taken oral medications. So it's important that we have the right resources to engage with patients at these different inflection points and understanding their unique challenges and barriers in order to see these best outcomes. Next slide. And so with that is the need for data. Profiling your patient population and identifying these types of barriers is the first step to measuring ROI. After all, patients who only fully commit to treatment and remain adherent are going to see the types of outcomes that we're expecting from GLP-1s. Benefit data, program data, survey data, workplace data are all important factors as we develop this profile. Next, before we can assess financial incomes, we need to first measure clinical outcomes. So before a diabetic patient can, let's say migrate from a stage 3 diabetic who costs like $15,000 per year to a stage 2 diabetic that costs like $5,000 per year, we need to first see that they're maintaining a lower HbA1c level. Likewise for obesity and losing weight or lowering their BMI. These biometric and lab data points are our bellwethers to outcomes, right? There are first indications as to whether or not our benefits, our programs, and our investments are working. And then obviously there's the always critical piece of financial, encompassing all these data types and giving us that true cost of coverage and true outcomes. Are we seeing that healthcare costs are improving, or are GLP-1s simply replacing the cost for other treatments? Next slide. So as you look forward, these are 3 takeaways I recommend for GLP-1 management. The first we just covered, the need for data. Secondly, payers should consider how their benefits are either supporting or impeding these successful outcomes. And then lastly, clinical outcomes are going to precede financial outcomes, right? Patients need to first see and maintain improvements in biometric and lab results before we see any sort of reduction in disease state or financial implications. So thank you all for your time today. With that, I'm going to pass it over to Brandy.
Thank you, Catherine. Good afternoon, everyone. My name is Brandy Hodar, and I'm a Senior Healthcare Analytic Advisor here at Merative. I've worked for over 25 years in the healthcare industry, and over the last decade, I've placed a strong focus on integrating social determinants of health with claims data to better understand populations. Today, we'll be talking about targeting mental health well-being. Before we start, we have a poll here for you to answer. The question is, are you partnered with a point solution vendor for your members' mental health concerns outside of your health plan? This could be a vendor like Lyra, Calm, Talkspace, or Headspace, to name a few. So please take a few minutes to answer this as we move on. Now more than ever, members are struggling with so much, from stress and burnout to loneliness and even isolation. Even something as simple as being a caregiver can drive huge amounts of stress on an individual or family, and this in turn can have an impact on their work. In 2024, we started to see more employers and health plans put a focus on creating a healthy, whole person. This often includes financial, physical, and emotional health. If we look at the 8 key distinct dimensions of well-being, interconnecting them all is an individual's mental health. Each individual's path in life is unique, but at the core sits a desire to be healthy in the 8 well-being dimensions. They are interconnected, and at the intersection of that is strong mental health to keep us dealing with changes and problems as they arrive. Wellness is essential for leading a fulfilling and thriving life. Prioritizing wellness helps us manage stress and depression, reduce illness, and cultivate positive relationships. We are going to take a look at mental health substance abuse claims, including a deep dive into depression. For the discussion today, we're using our Merative market scan commercial population and focusing on medical claims. While pharmacy drugs can play a big role in treating mental health, today's data is focusing on members who had a clinical condition documented by an ICD-10 code. When we look at the data, we see that 18% of the members have had a mental health medical claim in the last 12 months. Almost 6% of all medical costs are attributed to mental health substance abuse claims. And on average, over $28 per member per month is spent on these claims in the medical category alone. This can include depression, substance abuse, eating disorders, just to name a few. Now, while $28 does not seem like a lot, If you look at a member base of 30,000 members, that equates to over $10 million per year and does not include lost productivity or time taken off. When we look at depression claims, we see a rate of 56 patients with depression for every 1,000 members. Think about that. Out of every 100 people you know, 6 of them have had a claim for depression. Let's dive into depression and look at these, bringing in publicly available data to better understand disparities in the population. For this, we're going to use the CDC Social Vulnerability Index, or SVI, and here are fields available with the SVI. Today, we're going to primarily focus on the poverty levels of the neighborhoods that members live in. When we look at rates of clinical utilization, such as admits or ER visits, we see that as we move from areas of less poverty in a neighborhood, the purple bars, to areas of greater poverty, the green bars, we see the utilization start to increase. When we look at services such as a rate of preventative care visits for adults, we see the opposite. Members in areas of less poverty tend to get preventative care more than adults living in neighborhoods of higher poverty. Think about the concerns that might happen in these neighborhoods. Members might be working multiple jobs or working shifts where it's harder to get into an office or see that PCP for their preventative care. They may have to travel further to get to providers and may have trouble securing transportation. When we look at the fourth graph, the number of patients with depression per 1,000, we see a very similar trend to those preventative visits. While it's typically acknowledged that members in the lowest incomes are typically 1.5 to 3 times more likely to experience depression or anxiety, that is not what the data is showing. What it is showing is that members that are most in need of services for depression are not getting those services. Now remember, when we reference rates, these are recorded claims that have been documented through medical records. Members may reach out to services or vendors that do not submit medical claims for the engagement, or they may be receiving only pharmaceutical care. A common question that is what prevents people from seeking mental health treatment that they might need? It's easy if you have a physical ailment to understand the treatment you or a loved one might need. If your throat is scratchy or there's ringing in your ears, you might make an appointment or visit urgent care and attend to the concern. But when it comes to mental health concerns, there are many reasons that people avoid, deny, or even talk themselves out of needing medical care. Here are 7 of the major roadblocks experienced by populations that need mental health substance abuse treatment. Many believe there are stigmas attached to seeking treatment for mental health concerns. Some people believe they can handle their own problems and don't need to reach out or deter out for treatment, or they may not have the support of their family members and loved ones. Financial and structural barriers can delay or deter members from getting the help they need. And even lack of confidence in the effectiveness of treatment can postpone or delay care that is needed. Looking at other mental health concerns, we see that anxiety disorder rates mirror those of depression, with more members having utilization for services in areas of less poverty. While the clinical diagnosis of substance abuse, we do see slightly higher rates in those higher poverty neighborhoods. What comes as something interesting is that when we look at mental health substance abuse telemedicine, we see a 36% drop in the areas of least poverty to those with highest poverty. This is a great opportunity for education. The group in the 0 to 25th percentile might be better exposed to services available and understand how to access these services than, say, the group living in the 76th to 100th percentile of poverty. Slicing the metric by age and gender, we see that women are getting clinically documented with depression twice as often as males, regardless of the neighborhood poverty level. Nationally, the highest rates of patients are females between 18 and 29 in the neighborhoods with the least poverty, and with the lowest rates of recorded clinical diagnosis utilization occurring in men in that 55 to 64 years of age in the neighborhoods with the highest rates of poverty. When looking at the variations by location across the country, we did find southern states such as Florida, Texas, South Carolina have lower rates of services for depression across all 4 neighborhood levels. Interestingly, Minneapolis jumps off the page with the highest rates for all 4 neighborhood groups, and their neighborhoods in the 51st to 75th percentile is almost double the utilization rate of the nation, with women in the age range of 30 to 44 leading with a rate of 167 patients per 1,000 for depression. If we bring in a couple of other fields that are available with the Social Vulnerability Index, we see that there is a similar trend with neighborhoods that have high numbers of people that have no high school diploma. Here, the disparity is even greater between the 4 different quartiles. We go from a 17% disparity with poverty to a 30% disparity based on education levels. Looking at neighborhoods with high minority or limited English speaking, we see a strong lack of utilization of clinical services to treat depression, especially in those most vulnerable neighborhoods. This can go back to those roadblocks that we were talking about earlier, such as stigma within a community, financial barriers, or even lack of support from loved ones. Having an open and positive environment when it comes to mental health can make a huge difference in your members' well-being and happiness. The best companies are proactively providing resources, tools, and services to all workers and their families so they can seek and get the help they need. Here are just a few things that many employers are currently doing. Some are helping to end the stigma by encouraging their employees to discuss their mental health struggles. This can have an even stronger impact when stories are shared by leaders. Others make mental health a focus throughout the year, with health professionals and experts brought in to discuss specific mental health topics. And then there are employers and health plans who offer a wide range of services, from private sessions to wellness and fitness incentives. All of this is to target the overall health and well-being of their families. Now, while there's still ways to go before the modern workplace reflects the diverse needs of its employees, here are a few ways you can take steps in the right direction. Look for populations that may need to be educated about the mental health services offered by using SDOH datasets to better understand your population. This can include integrating data about your members such as education levels or race and ethnicity. Also consider understanding the communities that your members live in. This can be done by bringing in data sets such as shown today with the CDC's Social Vulnerability Index. You need to understand barriers that prevent your population from achieving their best mental state. Consider the barriers that impact your population. Do they have access to services in off hours? Is there value in bringing services on site or to your clinics? And hold your vendors accountable for the results. For those partnering with vendors for mental health services, are those vendors engaging the right members? Do you see improvements in all of your population or only those easiest to reach and target? Now I'm going to hand this over to Kevin Wade, and he's going to talk about what we are seeing with pricing strategies.
Thanks, Brandy. Appreciate it. I'm going to quickly touch on pricing strategies. I'm Kevin Ruane. I lead our analytic advisory practice here at Truven by Merative. Been with the company 20 or so years and been in healthcare my entire career. Want to talk about the pricing strategies as we look at putting all these different programs in place. If we go to the next slide. So there's a lot that can impact affordability, right? We're talking about the trend, and we have a couple of trends that we're seeing at the top that are predicted for 2025, right? An 8% growth in 2025, which is the highest since 2012 as a prediction. Employer-sponsored coverage is to rise 9%, which puts an employee cost at over $16,000. So these predictions are significant, right? And it's kind of really across the board. We've just pulled in 2 here. We've talked about a bunch of different strategies from GLP-1 to mental health to regulatory, but it's far-reaching, right? Even when we're talking about obesity and what Catherine was talking about today, the CDC has over 40% of the adult population is currently obese. We have 60% of the population, according to the CDC, has one chronic condition, 40% have multiple. So managing those chronic conditions is key. We have an aging population, so we have a lot of clients who are focusing on their Medicare Advantage plans. So 1 in 6 United States residents are over the age of 65, according to the last census. And that has outpaced the total population 5 times over in the last 100 years, and it continues to grow. So as we're looking to put our strategies together, our clients are doing a lot of great things. We've talked about some today, right? The prior authorizations, the benefit strategies, monitoring regulatory impacts. But we'd be amiss if we wouldn't talk about price, right? Price is going to have a huge impact here. So when we're talking about the big components, no surprise to anyone on the call today, is that utilization, huge driver, and price. So we want to be able to focus on all of that. And there's a downstream impact with the pricing strategy. So we're talking about member affordability, right? And member retention and member satisfaction. We have population health. Brandy had clear statistics on that, what actually happens when someone's in poverty. But from that affordability perspective, if they can't afford, they're going to delay care. We saw that in her stats where the admissions were up, the ER up, but the preventative care was down. That's going to exacerbate conditions, and people are going to delay care when it's not affordable. We have employer group retention. So as our health plans are struggling to stay competitive, we want to be able to retain those accounts and grow those accounts and partner with them. And growth and profitability in general. So far-reaching. So as we look at our strategy to control trend and focus on affordability, we need to be able to look at price in addition to all the different programs we have in place that we've touched on today. The next slide. So at Truven here, when we're working with clients on a pricing strategy, we really kind of put it into kind of 4 quadrants here, right? So I'm just going to kind of briefly talk through these. One, Medicare pricing is still a gold standard for a baseline. I started my career on the health plan side, and I did negotiate hospital and physician contracts, and Medicare was what was modeling against. It's still a key component that we want to be pulling into our analysis. These are publicly available, but they are complex. There's multiple fee schedules. There's different pricing rules. We partner with an actuarial company to apply it to our clients' data. But it is the common language that people are talking about, whether you're talking a payer, provider, consultant, what percent of Medicare are you? So we want to be able to look at that for sure. Brian mentioned that there is a 2.83% reduction in the Medicare fees for physicians. This is the 5th year in a row that there is a reduction. So it's really, a lot of scrutiny on that. And as Brian pointed out, as I'm looking to negotiate my contracts, they're going to be looking to make those costs up somewhere. So when we're looking at that, you want to be cognizant of what's actually happening with Medicare, because they'll be looking for those to make up those costs on the commercial side. So that's kind of key. And there's a lot involved here, right? What is your market share? Do you really have a narrow network, or are you contracting with everyone? So there's a lot at play, but that Medicare baseline is going to be key as part of your strategy. Also, machine-readable files, Brian talked about those a bit. So this is the transparency and coverage final rule to publish the rates, kind of a game changer. Been in place for a couple of years, and we want to be able to have that as a key piece of our analysis as we're looking at our negotiation. And they offer great promise. There are some drawbacks to them. Just want to talk through those really quick and considerations. Again, we absolutely want those as part of our strategy, but there's some nuances we need to be aware of. One, the size of these files can be massive. You're talking about a health plan, MRFs, they can exceed 1 gigabyte of data. So they can be very difficult to work with and pulling into an environment. So you want to be cognizant of that. And we're working with MRFs today. You want to be working with a vendor who can handle that scale. There's also the situation where the health plan and the provider MRF files are actually different formats, so that can make those difficult to compare. There is a lack of scrutiny on the accuracy of the health plan, regulatory oversight of the health plan accuracy of the files, as well as there is something called, you may have heard of zombie rates or ghost rates. Those are rates that are on these files that are clinically implausible, right? A mental health provider would not be doing a joint replacement. We hope not anyway, right? But that is going to be on the file, and it actually adds to the noise. So the accuracy is still an issue. We absolutely want these as part of our analysis, but we don't want it to be really the single source of truth. We also have paid claims benchmarks. I'll be talking a bit about this, but this is what's actually happened, right? You can't argue with what's actually happening in the market. So to be able to bring to the table paid claims, this is the utilization we're seeing. This is the range of fees that we're seeing from CPT code to admissions. And it's a good ongoing benchmark to assess the accuracy of the machine-readable files. And last, we have analytic reporting, right? There's a lot of different data sets here. I need to be able to pull this into an environment where I'm able to model it. There are over 700 DRGs, right? But when we look in market scan, I was looking at the most current year, the top 20 DRGs are driving over 30% of the payments, right? So this is where I want to be able to pull this into the utilization. What am I actually seeing in my own data? What are my provider ID hierarchies? How are my contracts set up? That is going to be key to part of this. Utilization is what we're going to be focusing on, because I could shave a few cents off a rate versus hundreds of dollars at another rate. If it is a high volume rate for me, it's really going to move the needle. So we're going to talk a bit about that. Next page. So we do have a poll, as we have the other. What pricing strategies are you applying today? So the ones we just talked to, as well, if there is something else interested. Again, we will be publishing all of these results out to clients and prospects, and we'll have this as part of the follow-up. So I see data and reporting, reimbursement benchmarks, Medicare, and a few nothing at this time. So we'll be following up with that interesting results and see what clients are doing today. Next page. I did just want to mention reimbursement benchmarks. So you've heard a bit about market scan, probably quite a bit, because we're using that for all the analytics, right? And there's a different lens that we look at market scan through, right? Depending on who the audience is, right? Are we pharma? Are we looking at utilization benchmarks? We have a view of the market scan data that is meant for contracting. When we're looking at contracts, there's a certain lens that we want to be able to look at it and pricing. So we take that market scan data and we apply methodologies in order to mimic contracts, right? So from an inpatient perspective, I want to be able to look at it from a DRG. My inpatient contracts often can be DRGs. I may have per diems as well. So we're taking that inpatient breakouts and calculating a DRG and per diems. Also, there's multiple ways we can look at outpatient, whether it's a case rate or by CPT code. So we have different breakouts there. So what we provide back to clients is a file of reimbursement benchmarks that would have the median, the percentiles, what the market is really bearing, so that when we're at the negotiation table, these again are paid claims, so they can really round out that picture for my negotiation strategy. I can see what Medicare is paying, I can see what the machine readable files are actually telling me, and I want to pull all those in, absolutely valid data points. But then this is the reality of what we're seeing in the market based on paid claims. So again, it's just a different lens into market scan, in addition to all the other views we were talking about earlier in the webinar. Next page. So here's just an example analysis and the power of pulling all of this together. So you'll see here, I just pulled in DRG 807, which is a vaginal delivery, and a CPT code for ER. This is, again, where utilization is going to make the biggest impact, right? You want to be modeling your data for sure. When I look at the market scan data, I mentioned that the top 20 DRGs are driving 30%, over 30% of the payments on the inpatient side. The top DRG in market scan, and I see this kind of consistently depending on the case mix across our clients, this is the top DRG for clients, as well as in the market scan data. In the market scan data in the last year, this was 4% of the inpatient costs on the DRG side. So I want to be able to really hone in on where those high volume DRGs are as I look to negotiate my contract. So this is just an example of pulling this all together side by side, right? So we can bring this to the table. And this is if I'm the health plan negotiating with the provider, if I'm the employer group talking to the health plan, if I have a employer directly contracting with providers, pulling all these facts together can really drive home the conversation and the negotiation at the table, having these facts together that you can talk about your providers with. So we have our client data here. First, from the client rate, what we're actually seeing in the data, right? This is calculated. We're calculating admissions. We're calculating claims. So we have the rate available here, and it is over $10,000 for the client. We have the number of admissions. Again, this is where volume is going to drive our impact, right? This is what's going to move the needle when we're talking about affordability. I've pulled in the hospital machine readable files. So from gross charges to cash price, plan 1, plan 2, plan 3. Depending on how many contracts they have in place, again, this is where some of these files are can be difficult to work with. But I have the 3 plans here. But I want to pull in all the different plans and see who my competition is. I have the health plan MRF, market scan, Medicare, and then I've calculated a savings opportunity. So this is where Plan 3 has the cheapest rate, but if I look at the market scan median, it's at about $9,700. And I'm just calculating the difference to say if I could get from my current rate to the median, and again, this is where I'm at the table with all these facts together. This is what the market's bearing. You've published these rates as part of the transparency and coverage regulations. I can calculate my savings opportunity to see where I'd make the biggest impact. So just getting it to the market scan reimbursement benchmark median rate, I'm saving at $1.4 million for this DRG alone. Similar to the CPT code for, this is just an emergency room CPT code, about $200 off, another $700,000. So again, this is the value of pulling this all together from a modeling perspective and also a strategy perspective. But then when you're at the negotiation table or your employer talking to the health plan, depending again what view you're looking at, it's a powerful strategy to pull all these facts together, use the data that we have and pull it together in a really meaningful way in order to drive that. And again, when we're talking about healthcare affordability, we can't overlook price. We have all these great programs in place, prior auth, all the great things our clients are doing today, but price is going to be a key component here, and we want to have a strategy in place in order to drive that down. Next page. So just takeaway, again, similar to the other areas, and probably not a surprise, use multiple data points, right? We don't want to, we have, sometimes you hear clients only using Medicare as the baseline, looking at machine readable files, all those different data points. We want to bring in multiple data points to have that complete story. You'll be more successful at the negotiation table when you have that, and you have that in front of you, in addition to assessing your utilization and what you're actually steering to the providers. We want to monitor changes over time. So this is, part Medicare reimbursement, right? That fact that it went down for the 5th year in a row is going to impact. There's the evolution of the machine readable files, usability and accuracy. Again, a game changer that these are all publicly available, but we want to be able to still monitor this and the accuracy of this and be careful. And then also work with a vendor who can take those in. We're taking in machine readable files, right? Those are massive files. And then any other regulatory changes, again, monitoring that is going to be key. And then the advanced analytic tools, right? The power of pulling this all together and modeling. These are a lot of different data sources, large files, pull it together in a very easy way so that when you're at the negotiation table, you can have that conversation and have all the different data points together. And I know we just have a couple minutes left, so I'm going to turn it back over to Manny to wrap up.
All right. Thanks very much, Kevin. And thanks to all of our presenters, Catherine, Brandy, and Brian. Really great content. We're almost right at the top of the hour, so obviously a lot of great insights to share. If you, we try to monitor the Q&A panel and answer questions via the chat. If we did not get to your question, we'll definitely follow up post-webinar and make sure everybody has access to those answers as well. We will also be following up again with the recording and the replay, so you can keep your eye out for that. Just wanted to point people to more thought leadership. You can head to merative.com/Truven. We have a thought leadership library there where we'll publish more content like this for our clients. We typically have webinars like this fairly frequently, as often as quarterly, where we dive deep into a specific area. Could be a webinar, for example, on mental health trends or on GLP-1s, as we talked about today. And so that allows us to give much more analysis and even get into conversations, have some roundtable discussions with our clients to see what they're working on. And so, great benefit to our clients. And for those of you who aren't current clients, again, we have this public thought leadership library where we're publishing blogs. We've got a analytics spotlight that we publish with regularity that, again, gets into some of this depth. So with that said, again, we're at the top of the hour. So appreciate everyone for joining today. And thanks again to our presenters. We'll keep an eye out for more from Merative here in the future. So thanks so much.